Welcome to How I Do It, a short video tutorial featuring leaders in the endoscopic spine surgery community discussing interesting topics that affect our practice. I'm neurosurgeon Dr. Paul Houle, and today we will be discussing how we do targeting for transforaminal endoscopic spine surgery, and our featured guest today is Dr. Ray Gardocki of the Campbell Clinic in Tennessee. So let's get to it. Hey, Dr. Gardocki, welcome aboard.
Dr. Houle, good evening.
So, Dr. Gardocki, you are an orthopedic spine surgeon and you are located in Tennessee, correct?
Correct, Memphis, Tennessee.
And you also are on faculty at the University of Tennessee?
Yeah, we're the orthopedic department for the University of Tennessee and the health science campus in Memphis. And I'm on staff at the Campbell Clinic.
Excellent. Is it true that the Tennessee Volunteers are second tier to the Roll Tide to Alabama? Is that true? Because my daughter goes to Alabama, and that's what she tells me.
Yeah, so the salary cap for Alabama is much higher than the rest of the teams in the SEC.
So you and I have had a long history together. We've taught a bunch of the endoscopic beginner classes together. And we have a certain way of targeting that we teach people. But just like everything else in life, there's more than one correct way of doing things. And you have a slightly different way of approaching the targeting. Is that correct?
That's correct. And in full disclosure, you are officially my mentor, as you're the one who taught me the initial basic course. Being much older than I am and much more experienced. So.
Well, it could be worse. It could be Dr. Telfian, who's like the grandfather for everybody. So hopefully he'll see this and be slightly offended. But ever from the very beginning, like the very first course, you're like, no, this would be a better way of doing it, and I actually agree with you. But so just a little bit of background for the people watching. You do your own transforaminal epidural steroid injections. Is that how you get started?
Yeah, actually, and I try to convince beginners to start doing their own transforaminal epidural injections. There's sort of three good reasons for it. One, diagnostically, it's fantastic. You can really pinpoint the pathology. So, for somebody to be a candidate for endoscopic surgery, basically you want to be able to answer three questions. If you answer these three questions, typically you can address their pathology endoscopically. So what root are they complaining about? What level is the pathology, and what's the pathology? So if you can have three very precise answers to those questions, say L5 root, lateral recess at L4-5 from a posterolateral contained disc herniation, boom, they're an endoscopic candidate. The transforaminal epidural injection that goes into Campbell's triangle is the best way to confirm the diagnosis, because if you get relief, you've confirmed that you know where the pain generator is coming from. It does a good job of predicting surgical outcome. There's at least an 80% correlation between relief of the injection and relief of the operation. And it even gives you a little dry run as to whether or not you can access the pathology through the foramen. That's important for, say, 5-1 for lateral herniations. There's some posterolateral herniations at 5-1 and a flat pelvis that you can access through the foramen, thoracic pathology. So it's a very helpful tool.
Yeah, I couldn't agree more. I know you've really it's been easy for you to transition to do an endoscopic spine surgery because I know that you had a lot of experience doing epidurals transforaminally beforehand, but sort of just tell everybody how you got started and some of the hurdles that you encountered and how you overcame them.
Yeah, so, I actually got started, the person who showed me the technique I used to do the transforaminal is actually Tony Young. So when I did my fellowship, Tony's son, Chris, was the fellow before me. He handed me his pager when I started my fellowship back when we had pagers. And after I finished my fellowship, I spent a week at Tony's house, watched him do surgery, watched all his videos, and watched him do injections. And I really understood the point of doing the transforaminal injections. I saw how the patients responded to the injections, saw how you got instant relief. So you got instant feedback as to whether or not you had the pain generator. And, when you start off in practice, you don't necessarily want to start off doing big cases. You can offer patients injections. They know then that you don't want to just operate on them. The only problem with doing the injections in the Campbell's triangle, you will inject yourself out of a lot of surgeries because a lot of those patients get better, which is a good thing. It's what I would want. So that's kind of how I got started. So the intent was to learn how to place the needle and place the endoscope through the foramen. That was the point of doing it, but it ended up being just an incredibly useful tool in and of itself. The pain guys and physiatrists in our area, and I'm sure in other parts of the country, they'd use a different approach for transforaminal injections. They tend to inject, for instance, an L4-5 lateral recess stenosis. They will inject the 5-1 foramen, but they will even inject lateral to the exiting 5 root. And their explanation is that the medicine traverses up the root and goes into the lateral recess and bathes the area, and it does in cases where there's not significant stenosis. But if you're evaluating somebody for surgical intervention, it's tight enough that you're actually going to consider a decompression. The nerve works like a cork in a bottle and stops the medicine from flowing proximal to the point of compression. Doesn't get to the place where the inflammation is, which is the source of the pain, and the injections just don't work as well in my experience. I've re-inject a number of patients who've had a traditional transforaminal. I inject it into Campbell's triangle at the level or just proximal to the level of the compression, and they tend to do better. So
yeah. So I know that when we teach the Joymax procedure, we draw the midline, and we draw sort of a rostral caudal line, and we mathematically figure, based upon history and patient body habitus, a lateral line. Say you're going to demonstrate an L3-4, and typically for me that's anywhere from 10 to 12 centimeters off the midline. Would you use this point now where you want to go over and narrate the video that you have that shows us your technique for targeting?
Yeah. So here we've brought the patient into the block room. We've placed him prone on the table. He's gotten 2 milligrams of Versed and 50 mics of fentanyl to make him comfortable. He's awake, alert, and oriented. In fact, when we do the timeout, the patient often participates, so we get feedback directly from the patient that we're doing the right level and right side. I'm going to show the images, the pre-op images on this patient, just because people are going to ask. They're not really relevant to this, but he's got a far lateral disc herniation on the left at L3-4. You can see there the disc displacing the exiting 3 root posteriorly up against the roof of the foramen. These are the T2 images. Sometimes the T2 image is a little tough to see the foramen. That's a pretty good view there. You can see the disc herniation dorsally displacing the root. So with the patient prone, the stick I use is an arthroscopic switching stick. The tip of the stick is the midline, and it's parallel to the displace. You get this image, and you can see on the AP image, the tip of the switching stick is in the midline. We just draw that line. We now know that's the midline. This is someplace out here is where we're going to go with our needle, and we're going to stay parallel to that line to target the foramen. We then get a lateral view, place the switching stick to the very front of the disc space, parallel to the disc again. And you'll see under the lateral fluoroscopic shot that the switching stick goes all the way to the front. We now have 2 lines 90 degrees to each other, which we will draw on the skin. These 2 90-degree lines define a plane that bisects the foramen and targets the Campbell's triangle exactly where you want. So that stick is now perpendicular to the X-ray. We grab the stick where the dorsum of the skin is, and then we go that distance from midline outward, and that tells you your starting spot. So just to kind of confirm, we're going to measure after we make all these lines, and you can see that this guy's kind of a big guy, and he's L3-4, and we're almost 11 centimeters out from midline, which is a little bit more lateral than you probably would be on a very small female, but he basically told us where to put the needle based on his size and body habitus. So now what we'll do is prep and drape this area. If this were an endoscopic approach, we'd have the full Joymax bag with the water bags. You anesthetize the skin at the mark, because I know that's where I'm going to go with the needle and the endoscope. If I was doing an endoscopic discectomy here, I would actually make my incision. Since this is a transforaminal epidural, I use a 20 gauge 6-inch needle. For the endoscopic procedure, we use an 18 gauge needle so that the guide wire will fit down the needle and insert into the foramen. And our target is going to be the lateral aspect of the facet joint. We want to go dorsal and medial to the exiting 3 root, land on the lateral aspect of the facet, ideally where the facet and joint capsule converge and the intertransverse ligament converges, and then skive off the ventral part of the facet into the foramen into Campbell's triangle. So you'll see here, I will tell the patient, hey, you're going to feel a little pressure at your side. You tell me if you feel pain go down your leg. You can see I brace my hand against the side of the body. I use 2 hands and advance the needle, and boom, I followed the 2 lines, kept the needle parallel to both lines, and we're right on target for the facet. So I can feel a little resistance there. I know I'm in the facet capsule. I might be skiving off bone a little bit, but I'm also very, very far from the medial pedicular line, so I'm still safe if I advance the needle a little bit. So you never want to go medial to medial pedicular line without checking your lateral, but since we're far away enough, I can advance a little bit, and I get some feedback that I've got some resistance there. So I can feel I'm skiving bone and pushing through the facet capsule, which is very thick and fibrous. So I've got some resistance, and I'm now about to the midpoint of the foramen on the AP. So we're going to check the lateral. So you need both AP and lateral to be sure where the tip of the needle is. And you can see under the lateral view, the tip of the needle is at the pars, about where the articular surface of the L4 supraarticular process is. So we're not quite into the foramen yet. The tip of the needle is actually in the facet joint, basically in the facet joint capsule, skiving off the bone. So we're going to use that bevel pointed downward to skive. If we turn the bevel posteriorly, it will dig into the facet. With it going downward, it'll skive and go ventral to the facet. I now advance the needle a little bit more, again, 2 hands and very gentle, and I can feel a little pop. That little pop is going through the facet joint capsule. And now under the lateral view, you can see I'm ventral to the supraarticular process of L4 in the foramen, at least on the lateral view. So now I'm going to check my AP to see how medial I am, because I can't tell from this view how medial I am. And you can see under the AP view, I'm basically at the medial pedicular line. So the traversing root is just medial to this. I'm going to advance the needle a little further here, because if you're doing, for instance, a posterolateral herniation, you could advance this easily ventral to the traversing 4 root, so that when you put your endoscope in, you're basically staring up at the inner surface of the root and looking directly at the disc herniation. So at this point, I would advance the needle till I just feel the slightest bit of resistance. I want to touch the annulus. I don't want to puncture it. If you had a contained posterolateral herniation, you may decide to go ahead and advance the needle into the annulus a little bit and anchor that guide wire in the annulus. That makes it a little bit more stable when you're doing your reaming. So that video was just about 6 minutes long, and that's pretty much what it takes real time to be able to do this in the OR. So it should take you 5 or 6 minutes to place the needle exactly where you want it and start your reaming process and start placing your cannulas. If it's really complex, it may take 10 minutes, but really shouldn't take much longer than that.
That's an excellent point, Ray. That needle, at the medial pedicular line, that's where people tend to get a little bit nervous and they're going to get a dural puncture. Speaking of which, if you get a dural puncture, what do you do? People ask, do you abort the procedure? I don't. It's just a little pinhole and it'll seal itself. Remember that you're on the ventral surface of the dura, and it'll seal itself.
And that's the beauty. There's no dead space there. So you proceed with your procedure, do it. When you see the nerves decompressed, you just squirt a little to seal. I mean, you could even do an acute blood patch if you wanted, just something to tamponade that. And we don't even have them lay flat or do anything afterwards. They just get up and walk around.
I mean, you being an orthopedic surgeon, I just assume there's going to be a blood patch. So, because in neurosurgery, it's so pristine that we'd have to use something like to seal. But no, but seriously, there is always a little bit of oozing and bleeding, and I've had one patient where we had to go in afterwards and do a blood patch. I think I've had 3 patients out of 400 that have had some sort of a dural puncture, and only one was symptomatic, and that went away with a blood patch. So I don't think it's really that big of a deal. So you have a whiteboard. You wanted to show something. Is that correct? Let me just switch over here. Go ahead.
Can you see okay?
Yes, perfect.
All right. So first thing I'm going to do is just going to kind of draw what a needle looks like. And if you'll notice, the needle is chisel shaped.
Yep.
And that's important, because if you're driving the needle in this direction down the shaft, the needle actually goes in this direction, just like a chisel. So if you've done any woodworking or you're an orthopod, you know that. If you're a neurosurgeon, I have to tell you. So, but this is important, because where you see this bevel of the needle pointing downward, that's how you want to insert it and land on the facet joint. Because that way, when you hit the facet, as you back up and you raise your hand, the needle will skive off the facet. If you do it the other way, the needle will dig into the facet and you won't be able to skive off the ventral surface. So that's just an important point for people who aren't used to driving the needle. This is just sort of a little sketch that I do to kind of explain to the residents and anybody who's trying to figure out this technique I'm using. See if I can.
That's perfect.
Here. There we go. All right. So the depth that we use to the front of the spine, we'll call that X. When you place your switching stick to the midline and roll it around the patient's body, and patient's body is not square, it's a little rounded, so there's a little bit of a cheat factor here. If you make this cube, you see you've got a square. Well, if I take that square and I go at a 45-degree angle, I'll end up at the front of the disc. So taking into account the roundness of the patient and the fact that you're trying to end up here, if you go in at a 35-degree angle, boom, you end up right in the lateral recess in Campbell's triangle, right next to the traversing root. So the two perpendicular lines define a plane. So the reason I like to draw those lines on the skin is, as you're advancing the needle, if you just keep the needle parallel to those two lines at the same time, you're going to end up in that same plane. And then it's just the depth that determines where you end up in the foramen. So if you come too superficial, you end up posterior to the facet. You don't want to go too deep, because you don't want to poke anything in the retroperitoneum. So you want to cheat posteriorly. And if you can hit the facet posteriorly and then use that bevel to walk off the facet, you'll end up right where you want to be in the foramen. So for the description that we used on this video, that's like a perfect spot for a posterolateral herniation. That's exactly where you want to end up. And you got to keep in mind that if you have a contained posterolateral herniation, that nerve, that traversing root in that lateral recess, is actually displaced posteriorly. So as you advance the needle, it's almost impossible to hit that nerve because it's dorsal to you. You're going ventral to it. If anything, you're going to stick the needle into the disc. You do have to be careful if it's an axillary herniation, it's pushing the traversing root laterally. That's something you need to be aware of. And it's also why you start being much more detailed when you evaluate your preoperative MRIs. These little details like that make a huge difference.
And you know, as we always say, the needle placement is the key to the procedure and everything else follows. And I think you've just demonstrated another very useful and very safe technique to access the epidural space to get both a push or lateral herniation as well as a foraminal or extraforaminal herniation. So just a wonderful explanation. And I really thank you for taking the time out of your day to teach all of us. These are trying times, and it's nice to have a little bit of time for some scholarly activity. So thank you very much for joining us and teaching us and giving us another way of doing things.
Well, thank you, Paul. And I want to thank you for doing this, because this is a great idea, especially in this craziness in the world right now, to be able to watch some of these videos and see what other people are doing has really helped my practice and my use of the endoscope. So keep up the good work. This is awesome.
Thanks, man. Well, have a good evening. Hold on. I'm just going to do a shameless plug for myself, and then we'll go from there.